Hi, and welcome to the annual ARJO Stop Pressure Injury Day webinar. ARJO is proud to run these webinars every year to coincide around the time of Stop Pressure Injury Day. Of course, Stop Pressure Injury Day occurred last Thursday, the 19th of November, and we here at ARJO look closely at collaborating with some of our clinical users of our equipment, as well as the Australian College of Nursing, to bring an education platform surrounding Stop Pressure Injury Day. This year, ARJO is proud to introduce to you Andrea Kirk, who works at Western Sydney Local Health District in Western Sydney, primarily around Westmead Hospital, Blacktown, Auburn Hospital. Andrea will talk to you about the challenges associated with pressure injury in the darkly pigmented skin population. But first, a little bit about ARJO from me. So ARJO is a Swedish company. We've been operating since 1957. ARJO employs over 6,000 people globally, and we operate in over 100 countries. ARJO's primary purpose is to provide solutions for those that have reduced mobility or capacity to improve mobilisation, or indeed to retain mobilisation in our patients and residents. ARJO utilises its philosophy of the positive 8. So the positive 8 looks at the patient at the top, the caregiver at the bottom, and the environment that care is taking place. So from the patient or resident's perspective, we're looking at mobilisation, improving that functional status of that mobility, improving quality of care. For the caregiver, for the nursing staff, for the physiotherapists, for those that are caring for residents and patients that have reduced mobilisation, the thought is around providing support, providing solutions to reduce injury, to reduce caregiver practices associated with causing a deterioration in their status. And this is all around the environment that clinicians are working in. So collectively, the patient, the resident, with the caregiver and the environment, form the positive 8 that surrounds the ARJO philosophy in improving mobilisation for our patients and residents. ARJO talks about the mobility gallery, and the mobility gallery is a process where we break residents and patients down into 5 stages, easily remembered by the acronyms Albert, Barbara, Carl, Doris and Emma. Albert being someone that's able to self-mobilise, and Emma, right at the other end of the scale, someone that has very complete requirement for support, etc. So all of those patients or residents between Albert and Emma, we like to think of the equipment and the strategies to enable and to provide strategies for mobilisation amongst that group. Of course, not only the general patient population within our mobility gallery needs to be considered. There is the mobility gallery for our bariatric patient group as well, that have a specific requirement from a mobility perspective, but also have specific nuances associated with the caregivers and the caring of those patients and residents. To do that in a method that is reducing the risk of injury to the carers, but also retaining the level of mobility for those patients and residents. But today's about pressure injury. So what I want to do before I introduce you to Andrea and go through a whole lot of in-depth understanding of pressure injury associated with darkly pigmented skin, let's check your level of understanding. So there's a poll manager on your screen. So checking a poll, we're going to open up a couple of very basic questions to get some involvement here, because I know during a lot of these webinars, it's easy to listen to information coming through without participating. So before introducing you to Andrea, I have some really quick questions to ask you. The first of those questions, and read back, I'll ask you to open the first poll, is just to check your level of understanding. So thinking about pressure injury, what is the primary cause of pressure injury? Is the primary cause of pressure injury A, diabetes, B, immobility, C, heart failure, and D, incontinence? So that poll is open for you to all answer at this point, and let's see how those answers are coming through. I've got 97% of you that have answered immobility, and yeah, that's correct. We had a small number of people that also answered incontinence, and certainly incontinence is important to consider for patients from a pressure injury perspective. But the primary cause of unsustained pressure injury is, the primary cause of pressure injury is that level of immobilization or the inability to move that causes pressure on the skin and tissue. The next question. Let's open the poll on this one. The most common site for pressure injury. This will be interesting to see what the thought is out there. Is A, the sacrum, B, shoulder, C, trochanter, or D, heels? Let's have a look at everyone's thoughts around the second question. What is the most common area for pressure injury? The results are coming through now. Interesting to see these results as they come through. We're seeing a number of you have answered heels and a number of you have answered sacrum, which is what we typically see when I look through this poll. The answer is actually sacrum. The sacrum is the most common area of pressure injury, but of course the heels is another area that's at great risk. Of course, the heels are the most distal, and in patients that have vascular disease or diabetes or mobility problems, there's poor perfusion to the heels in some of our patients and residents as well. But the sacrum is the most common area for pressure injury, closely followed by the heels. The next question. Let's open this question up to you all to have a look at. Pressure injuries are preventable, A, only in patients or residents that can follow instruction are mobile, B, in all circumstances, C, in mobile and immobile patients or residents in most circumstances with the correct nursing measures and equipment, and D, in critical care units only. I'll be interested to see what we are getting with this answer. So we've opened the question up. I can see the polls are starting to come through. I'm seeing a couple of answers here as the polls run, so I might just let this poll run for just a little longer as we're seeing the results come through. I've got a mix between B and C at this point, which is a mix between in all circumstances and in mobile and immobile residents in most circumstances with the correct nursing techniques. And the answer is in fact C. So it's preventable in the vast majority of circumstances. There are limited examples where it's not preventable, and those limited examples might be, for example, a patient that has got a suspected C-spinal injury that is kept on a spinal board for a prolonged period of time and flown between a distant hospital from one location to another. That might be unpreventable, but in the vast majority of circumstances, pressure injuries are preventable. Let's move on to the next question. When doing a skin assessment, you should check for the following as an early indication of pressure injury. Let's open this question. Is it A, skin temperature, B, skin moisture level, C, non-blanching erythema, or D, blanching erythema? Be interested to see what we're getting from this question. So the question's open now. Seeing the polls come through. Respondents. So I'm getting a mix between a couple of answers here. I'll leave it open for a couple of seconds. I've got 25 respondents so far, 19, 20. And the majority of you have said non-blanching erythema, which is C. So that's the correct answer. So when doing a skin assessment, you should check for early indications of pressure injury. So blanching versus non-blanching erythema, that's the whiteness. When you touch reddened skin and push it, it becomes white. That's blanching. If it is non-blanching or remains red, that's indicative of early stages of pressure injury, or indeed stage 1 pressure injury. And Andrea will talk more about that shortly. Final question. Let's get this one going before I introduce you to Andrea. So let's open this question up to the audience. The following are pressure injury assessment, risk assessment tools that you may be familiar with in your clinical practice. So we've got A, Waterlow, Bradlow, Norton, C, Waterfall, Currajong and Braden. Sorry, that was B. C is Waterlow, Braden and Norton, and D is Currajong, Waterlow and Norton scale. We're getting a few responses coming through now. I can see those coming in live to me. Great to see the interaction out there occurring. Thank you all for participating. And I'm just about to close the results. If anyone wants to have a final response, I've got near on 90% of you that have answered correctly, which is C, Waterlow, Braden and Norton scale. So they're the scales that we use to assess pressure injury. You may have seen in your clinical practice. Before handing over to Andrea, I wanted to just finish with a final slide, and this is a quote from the latest pressure injury guidelines as to what a pressure injury is, a definition of a pressure injury. And I'm going to read it out to you and then leave this with you as Andrea runs through her presentation, because there are some points in this definition that are of high relevance in terms of what Andrea will speak to you about shortly. But a pressure injury is defined as a localized damage to the skin or underlying tissue as a result of pressure or pressure in combination with shear. And pressure injuries usually occur over a bony prominence, but may be related to medical or other devices. So on that note, I'd like to introduce you to Andrea Kirk, who will take over from me and talk through with you the impact of pressure injuries or the issues around pressure injuries on patients or residents and the challenges of patients or residents with darkly pigmented skin. Andrea, thank you once again for doing this presentation for us, and I'll hand over to you. Thank you, Andrea.
Hi, thank you so much, Phil, for that, and thank you to RJ for inviting me here to do this presentation for you all. So, as Phil mentioned, I'm the Pressure Injury Coordinator in Western Sydney Local Health District. So I have the pleasure of going around to multiple facilities and working with all of the nurses within the district to try and reduce some of those pressure injuries. Just to give you a brief introduction, to summarise what we want to look at, prevention and early detection of pressure injuries, which you will see written as PI, is essential. And the ability to detect changes early is key. And with darker pigmented skin, this obviously presents a challenge, as often those subtle colour changes, they're not easily detected. So using the latest evidence, that helps us to reduce the risk of pressure injuries to patients. So part of the recent evidence that has come out is the prevention and treatment of pressure ulcers/injuries, and that's the clinical practice guideline. So that was actually released in December 2019. And so in order to give you a definition, as Phil mentioned earlier, of what a pressure injury is, so it is that localized damage to the skin and or underlying tissue. And I think what I tend to see when going around the district is that often people can get confused with what a pressure injury is. So if we break it down to it being over a bony prominence, so that's areas like your heels, your sacrum. So you want to have that area of bone that is protruding a bit more in that localized area. But it can also be related to a medical device. You need to have pressure over that area or pressure in combination with shear. So you can actually get skin intact with this, or it might be an open ulcer, and it can be painful. So it often occurs as a result of intense and or prolonged pressure, or the pressure in combination with shear. So So what this means is the tolerance of soft tissue for pressure and shear may also be affected by things like microclimate, nutrition, perfusion, comorbidities. So this is often divided into your intrinsic and extrinsic factors. So just to go to a bit of background, it's just interesting to know where a lot of these terms come from. So decubitus was the first used term, and it was gangrena per decubitum in 1777, and all that means is dead tissue due to lying down. So when we break down what these words mean, you've got the gangrena, which is the dead tissue, and decubitus is that lying down part. So it's very simple with how they've been termed, and even going back to these dates, people could see that these injuries were happening due to people lying down and not being as mobile. And then you've got Florence Nightingale in 1859. She actually documented them as bed sores. So that's probably when you come to a more familiar term. And this is certainly something that I know if I'm trying to explain to someone from the public what my job is, I say I try and prevent bed sores rather than saying pressure injuries, because this is a very common term. And then in the 1980s and 90s, so in the 80s, it progressed to pressure sores, and then in the 90s to pressure ulcers. But what we tend to find now is most of Europe is still using the terms pressure ulcer, whereas Southeast Asia, Australia, New Zealand, and the US tend to be using the term pressure injury. And so that's what we've moved on more now to kind of describe that it's actually an injury rather than it being some sort of sore. It's highlighting that fact that harm has been caused to the patient. So when we look at causes, superficial pressure injuries often caused by high shear, and this is happening at the skin surface. And then you've got your deeper pressure injuries, which is that high pressure in combination with the shear at the surface. So what we know now is that tissue deformation is actually happening deep within those tissues. And what we find from that is that your stages 4 are working from the inside out. So it also highlights the need for a comprehensive skin assessment, because often you will feel any tissue changes before you can see anything visible. So this is particularly relevant in darker pigmented skin, but it's also relevant, and looking at the most updated guidelines, we can see that they recommend a comprehensive skin assessment. So not just looking at your patient, but actually touching them, seeing what that tissue feels like. So here we have a picture, and this is from the NPIAP, and they're an excellent resource to get pictures or information and latest evidence from. So when you look at the skin, just to go back to a bit of that anatomy and physiology, so you've got the epidermis, which is the top layer, the dermis, and the subcutaneous layer. And then below that subcut tissue, you've actually got the deeper structures, which are things like your muscle, bones, tendons, and those sorts of structures. So then when you actually look at that diagram of the skin, you can see that you've got sweat glands, which are the curly blue little bits. Then you've got hair follicles, sebaceous glands, blood vessels, nerves, and sensory receptors. And with the hair follicle, you've also got muscles, which allows the hair to stand on end when you're cold, which helps warm you up. And you've got sweat pores there as well, which aid in the cooling. So we have to go back to basics and think about the skin. So it provides a barrier, and this actually protects us from bacteria. It helps regulate our temperature. So it's really important that we've got that intact skin. And it's also there to help us feel sensation, and it communicates with the brain. So from a very basic level, it's helping us to function with daily life. So moving on to the next slide, this is a stage 1 in a darkly pigmented patient. And what I want to highlight with this picture is that it's actually very difficult to see those subtle changes in the colour. So you can see in the dermis that redness, there's definite tissue damage happening further down. So we can see that there's already that damage occurring. But if you look at the top, to see that real subtle change and that redness is actually really difficult. So this is where, again, that comprehensive skin assessment comes in. And this will be a big focus in terms of darker pigmented skin, because just by looking at it, you're not going to see those subtle changes. And they often are particularly subtle as well. So just to touch back on what Phil was saying with the blanchable versus non-blanchable, I know that I'm very visual, and I think a lot of nurses are. So I feel like this picture makes a lot of sense. So on the left-hand side, you can see when you press that area of skin and you hold that down for 3 seconds, and this is recommended in the international guidelines as well, you can actually see that there's a white area, and so the blood flow is coming back into that area. Whereas on the picture on the right, they pressed it and it doesn't change colour, and it will just stay that same red colour. However, relating this back to darker pigmented skin, we also have to be aware that often darker skin tones rarely blanch anyway. So you're not only going to struggle to see those very subtle colour changes, but you're also going to have some difficulties in seeing that blanchable area, because it's just not going to react in the same way. So on to looking at some of the stages. So if we just go into stage 1, and this is important because, again, I do see people as I'm travelling around who think that a stage 1 is blanchable erythema. And if we see that redness that's blanching, if you think about when you cross your legs and you get the redness on the side of your knee, in essence, that is the beginning of a pressure injury. So it's important that when it's being classified and it's going into that staging, that it's non-blanchable erythema. And the skin is always going to be intact as well. And again, going back to the what a pressure injury actually means, it's got to be over a bony prominence or underneath a medical device. So you might have changes relating to darker pigmented skin. It's actually going to appear differently. So you might have changes in sensation to that area, or there might be slight changes in temperature. It could be warmer, could be cooler. And often there'll be a firmness underneath, so it'll be a bit harder. And you'll often feel those subtle tissue changes before you actually see the redness. So whether that's darker pigmented skin or lighter pigmented skin, you're going to feel those deep tissue changes. So we also need to remember that it's always going to be that erythema, that non-blanchable erythema. It's not going to have the colour changes. So it's not going to look purple or maroon or any of those colours, because they're going to indicate more of a deeper injury. Then with stage 1, it's basically where the epidermis and dermis have come apart. So it's just a partial thickness skin loss, and that dermis is exposed underneath, which is why it's often pink or red, often quite moist, because you lose a lot of fluid through these partial thickness wounds as well. You're never going to have any sort of fat or any of the deeper tissues visible. So as a general rule as well, the slough and eschar won't be present. However, this can happen in the odd occasion. But it's going to be just that top layer, just down to the dermis. So this is where it can be confusing, because your stage 2 can often be confused. So things like moisture-associated skin damage or incontinence-associated dermatitis, some of your medical adhesive-related skin injuries, or possibly traumatic wounds can get confused for a stage 2. So it's really important that we go back to that, what a pressure injury is, and think, is it over a bony prominence? Is it under a medical device or some sort of device? And also, if we think back to the history of the patient, it's really important that we get a history of them. So, for example, I've seen a pressure injury. It looked like a pressure injury, but when I went back later to review it and how it had progressed, it actually appeared to look a bit more like a burn. So they can be very confusing, and because it was over a bony prominence and this patient had had a long life, it's quite easy to think it's a pressure injury, but then with how it progresses and over the next couple of days it gradually got deeper, we realised that this was more likely to be some sort of chemical burn from the fall. So then we go on to the stage 3 and 4. So these are the full thickness loss of skin. So in a stage 3, you're going to start seeing that adipose tissue. So the fat is going to be present, and you're also going to have rolled wound edges often there. So you might get some slough or you might get some eschar, but really important to think about this. So you can see on that picture on the left of the stage 3 that the slough is just in a small part of the corner. So we can actually classify that as a stage 3. We can see enough of the depth of the tissue. The slough or the eschar is not lying over any of those deeper structures. So you might also get some undermining and tunnelling with this, but you're not going to get that fascia, muscle, tendon, ligament, or any of those exposed. And again, like I say, the slough or eschar, we need to think about where it is. If it's obscuring the extent of tissue loss, then it's going to be an unstageable. So then with your stage 4, again, full thickness, but you're going to either be able to see or directly palpate the fascia or muscle, tendon, and all of those. Again, you might have the slough or eschar, and you can see that on the picture in the right, that you can see there's some sloughy areas in there. But you can still see those deeper structures, so it's not actually covering up what we need to assess for the stage. So you've got to think as well, with classifying pressure injuries, you're not looking at the depth of tissue lost. So for example, if you think about maybe someone like Kim Kardashian, so she's got a slightly larger bottom, so it might take her a bit longer, you know, you're going to lose a bit more tissue. However, if you think on your nose, so this little bit here where your BiPAP masks sit, then that's not got much skin protecting it, so it's actually going to wear down a lot quicker. So then we go on to what are partly temporary. So if you can actually take patients to theatre and debride an unstageable or use autolytic debridement, then you can actually determine the depth. Once that slough or eschar is taken off, you can actually see what it is. And more often than not, it's likely to be a stage 3 or 4. So the aim is to get that off. However, stable eschar, so if it's dry, adherent, intact, there's no erythema or anything like that on the heel, or particularly in an ischemic limb, then you really don't want to be softening and removing that, because that's providing that protective layer over the top. So then we have the suspected deep tissue injury. So in Australia, we're still calling them suspected deep tissue. Some places you might hear of them referred to as deep tissue. So it's going to be persistent, non-blanchable, and it's going to be deep red or maroon or purple. And often you'll see it intact. It might be slightly non-intact, and certainly if it does continue to break down, then you're going to lose that top layer of skin. So often you'll have epidermal separation, so you'll have a dark wound bed, or it might look like a blood-filled blister. Again, this is really important to put into context with their history. So they might have come in with something that's a bruise. So making sure that they've not had a sprain, and we're not confusing the bruise from the ankle sprain with a pressure injury. So think about the history and what's happened, and also the fact that it's non-blanchable as well. So often you'll have the intense, prolonged pressure, and possibly with the shear forces as well. And this is often going to happen at the bone-muscle interface as well, and that's where this deep tissue deformation is happening. So the idea with these is to offload as soon as possible, and they can resolve pretty quickly, or they might actually have some tissue loss. So again, with these, if you get that tissue loss within a reasonable time, and you can then see what stage it is, so again, most likely to be 3 or 4, that's when you can actually go in and stage this. But again, we don't want to get confused with the vascular or traumatic or neuropathic conditions that could present as this similar sort of wound. So again, getting that history off the patient is very important. So there's one final classification, and this is mucosal. So the mucosal is found anywhere where there's mucous membrane. So it's always going to have a medical device in that area. So that might be the ET tube, as this picture shows, or it might be at the tip of the penis from a catheter. Of the anatomy of the tissue. So we have to stop and just call them a mucosal. The white part is often the coagulum. So if you think, if anyone has anything on their lips, to just stop and think mucosal. So the other classification that we want to be aware of is medical device related. So this is an etiology rather than a classification. So it's still going to be staged as per normal. So you'll have your stage 1 or 2, or potentially a mucosal if it's from the ET tube. And we just want to monitor what's causing it. So if it's the TED stockings, because we need to keep an eye on how and where these are happening and why they're occurring as well. So with skin assessment, this is important with all patients, but particularly, like I mentioned, with dark pigmented skin. So you want to complete your comprehensive skin and tissue assessment, and this should happen as soon as possible after admission, and it should be a high priority, because this way we can determine their risk. If they've had previous pressure injuries or they've come in with one, we know they're automatically at higher risk. And it should be head to toe. So you're going to have that focus on your bony prominences and under the devices. So shoes would need to come off, head stockings, anything that they've got on, oxygen tubing, you want to have a look under it all. So often, when you're doing your comprehensive skin assessment, pain over that site is actually a precursor to breakdown. So pay attention. If you touch an area and a patient says, ouch, then we want to be aware that that needs to have a close eye kept on it. So you want to look at your sacrum, ischial tuberosities, greater trochanters, heels, but also not forgetting other areas like the occiput, particularly in children and neonates, because it's such a larger circumference, they're at higher risk. But also often your patients that might need intensive care will be at higher risk as well, because they're not going to be able to offload that area themselves. We also need to be aware of obese patients, and that you can actually get pressure injuries from the extra adipose, so the fat tissue that they've got. So we should be checking under these skin folds as well, and that way you can also see if there's any moisture-associated skin damage as well. So when you are completing a comprehensive skin assessment, you really need to look at the colour. As I mentioned, in dark pigmented skin, with a stage 1 or a suspected deep tissue injury, you're actually not going to see those colour changes. And this is where it's important to look at the tissue texture and the temperature. So we know that early detection can actually help reduce the risk of them actually getting skin breakdown. We also want to think about the skin temperature. This is a really important consideration, and there is a number of evidence relating to this. And so in particular, cooler temperature in the centre of an area that's actually discoloured that's predictive that a pressure injury is going to actually develop there. And we also need to be aware of adequate light. So things like natural light or pen torches can be really good. These can show those subtle changes in colour and texture. So, you know, if you're working a night shift and you're doing that comprehensive skin assessment, we need to get that light on, because otherwise you're just not going to see those subtle changes, particularly in the darker pigmented skin. And we're also going to, when we're assessing the risk of pressure injuries in that skin, you're comparing it to the normal skin around it. So you're assessing for the edema and changes in tissue consistency, and that's compared with the surrounding tissue. So if you're pressing on the sacrum, you're going to want to compare it to just outside. So subepidermal moisture, so it measures soft tissue edema, which is below the skin surface. So edema is an important aspect, and that can lead us on to some technological advances that can actually assist with monitoring or detecting these changes. So in 2008, Bates and Jensen et al., they introduced them as an actual parameter for predicting. So we know that hydration occurs normally within the subepidermal tissue, and it's normal, but that inflammation that occurs due to that damage actually increases the subepidermal moisture. So we have SEM scanners that are available. So the National Institute of Clinical Excellence, which is the UK governing body, in 2019, they actually had a look into the SEM scanners, and they actually found a reduction in nursing hours, and they had increased savings. And this was based on reduced admissions from using the SEM scanner. So people weren't in hospital as long because they weren't getting the pressure injuries. So they were picked up and detected earlier, which meant they could bring into place preventative strategies. And also, studies have shown a correlation between skin that looks damaged and that higher SEM reading. So that's the same with Bates Jensen. In 2008, they found this. And it's currently tended to be used on the sacrum and heels, and it just detects those moisture shifts that we're not going to see or potentially feel as well. So it's going to give an average reading, and if this is too high, then it's indicative of damage. And this is particularly important in darker pigmented skin, because if we actually can't see those visual changes and it's very difficult to have a look at those areas, then this is some extra equipment we can bring into play. So stage 1s are not recognised in darkly pigmented skin people. So they're a lot more underreported, and this is most likely due to the redness being more difficult to see. And this then has a knock-on effect, which means that your stage 2 to 4 is often statistically higher in darker skin tones when compared to lighter skin tones. And that was shown in 2004. So this is not new information. This has been around for a long time. And the reason that it's likely to go to 2+ is because that the preventative care is actually delayed, which in turn is going to increase that risk. So in lighter pigmented skin, you're going to see that non-blanchable erythema. You're going to put into place more preventative strategies. So whereas with darker pigmented skin, you're going to miss it a bit more, which is why the comprehensive skin assessment and using this technology is so important, because that can actually detect these early changes. So with starting to complete a comprehensive skin assessment, we can start to reverse this trend. So when we're inspecting darker pigmented skin, we really want to look closer. So the area will most likely be cooler to touch and boggy if you've got a suspected deep tissue injury. Stage 1 will also show temperature changes. You'll get the pain and the tissue changes. So it can be difficult to tell the difference between the STTI and the stage 1, but the importance is to think about offloading and increasing movement and bringing things in like preventative dressings. So Rosen et al. In 2006 showed that by assessing the temperature, it actually greatly reduced the pressure injuries in darker pigmented skin. So it is a real early sign. And then again with the SEM, Bates, Jensen in 2009, the findings with their SEM scanners were particularly relevant to the darker pigmented people as well. And also using that light, so the pen torch from a low angle can help, and also moistening the skin. So it can show the texture changes and also making sure the area is clean and dry. So there is also another way, but this would need to be done on admission. So you can use these colour charts. So in 2016, McCreath et al., they used the colour chart on initial assessment and then noting the colour and continuing the use. It was actually more accurate in predicting stage 1 pressure injuries. But unfortunately, that didn't translate to predicting anything higher. But at least if you could stop those stage 1s, you're stopping that process. There's not a huge amount of evidence with it, but it could be a useful thing and something to think about implementing where there is a high population of darker pigmented skin to get a more accurate colour change. So it would need to be noted on initial assessment and then continued with the same chart throughout. So in terms of tips for assessing, so darker pigmented skin, it is more difficult to assess. So I think if we err on the side of having a higher suspicion of pressure injuries, and we know that events leading to pressure injuries can occur 48 hours before any visible change is there. You know, and this is exacerbated in darker pigments due to the changes being blunted by the pigment. So just suspect the pressure injuries with them. We want to make sure that lighting's good, so a pen torch or natural light if possible. You're always comparing that skin to the nearby areas. So erythema isn't as obvious, and it could even present as being darker patches. So by comparing that close skin, then you're going to be able to help see those subtle colour changes. Again, you've got the colour chart, and that can be slightly more objective. Moistening the skin, as I said before, so it can rehydrate the epidermis, which improves inspection, but it also allows you to recognise those changes. So actually touch the skin. We want to feel, is there any edema? Is it hard? Is it cool? And if you use the back of your hand, you can identify temperature changes easier as well. So it might feel boggy, it might feel hard. And a stage 1 might actually appear slightly hotter in the initial phases. So we need to understand the variations in classification presentation. So suspected deep tissue, they're not always necessarily going to be purple or maroon. They might be grey, black, brown or blue, whereas your stage 1 is always going to be red and non-blanching. Consider using your technology. With a thermographic measurement, you're going to tell those temperature changes, and your SEM scanners, you're going to see that moisture shift. So dark pigmented skin is thicker, so superficial wounds will be seen easier, but the open wounds often retain the epidermis because they've got more corneocytes, and that makes it thicker. And that's why the thicker epidermis can then remain on the edges. And also to think about the history. So they might get hyperpigmentation with the darker pigmented skin, and you can therefore see colour in the changes in the colour of the skin from previous wounds, so knowing if they've had previous pressure injuries. There can also be post-inflammatory hyperpigmentation, which can happen in the darker pigmented skin as well. So again, it goes back to knowing the history of your patient and thinking about these slight colour changes and doing an assessment and documenting that assessment quickly and carrying it out can allow others to then see what you've written, so you know if there's any slight changes over those bony prominences. So just to go on, a little bit of the impact of pressure injuries. So there's a reduced quality of life. Often people will have pain, a loss of or a decrease in function. They get loss of independence in activities of daily living. If you think it's on the heel, that can affect them walking. And that can lead to things like depression, anxiety, and worried about how they'll cope in the future. This also has a knock-on impact to family and friends. And I know from past patients and stories that there is a big knock-on impact to family, particularly if you think about Australia and it being such a big country in terms of people having to fly from state to state. And we only have to highlight at the moment with COVID and a lot of the borders having been closed that this might not have been possible for relatives to come and visit. You've got the impact, they might have been the main breadwinner, so then they potentially can't work, and this puts an economic burden. And this is all linked in with the mental health decline as well. There's increased anxiety, embarrassment of going out because the wound might actually smell. They're concerned the dressing might fall off, so they're very limited in what they can do, and that has a whole increase on the family strain as well. And this has actually been noted from people that have worked in the community as well. And so basically, I just want to highlight that understanding what a pressure injury is and knowing those few techniques we can use to actually look at darker pigmented skin can help prevent a lot of these pressure injuries in people. And as we know, most of them are preventable. So I'm happy to take any questions now, and I will answer questions about my hair colour too.
Thank you, Andrea. Wow, what a fantastic presentation. I've certainly learned a lot during that. Now, we do have a number of questions that have come in during your talk there, which I'll go through with you in a moment. But just before I do, just to let everyone know, we have put some resources that you're able to download. If you just click on the blue arrow at the top bar of your screen, there are some resources that we've put up there to enable you to download. I have a question as a starting point, and this is one from me, but just going through what you've run through during that presentation, Andrea, I've heard before that patients that have darkly pigmented skin are at higher risk. They're a higher risk group. So considering everything you've gone through, is it due to that initial missing, that initial early assessment, that ability for clinicians to be able to feel, to see, to understand during that initial skin assessment that something's abnormal and a pressure injury is coming? And if that's the case, are there any strategies, any clinical strategies that you might suggest in terms of being able to make that risk level a little less as a concern for patients that have darkly pigmented skin, for those under your care?
Yeah, that's a really good question. So I think, like I said previously, a lot of it is because those early subtle changes aren't detected. I think the key is to have that high suspicion. We know if our patient's at risk. You can, you've got your water, you've got your Braden, you can look at a patient and you can instantly see that that person is going to be at risk. So if they're darker pigmented, I think we need to implement those prevention strategies. So looking at things like preventative dressings, thinking about having an alternating air mattress on them and turning them regularly. So let's not forget, actual offloading is always going to be the cornerstone of good pressure injury prevention, but also utilising that touch, actually touching your patient, engaging with them, asking them if they're in pain, comparing that normal tissue to those bony prominences. And all of that together should help to reduce those risks.
Thanks, Andrea. Another question that's come through. In your experience, do you think nurses know how to use skin or risk assessment tools effectively? And beyond that, are clinicians doing appropriate skin assessments in their daily practice?
Yeah, again, another excellent question. I think risk assessments can be very subjective. And if you actually don't know, for example, with the waterlow, if you don't know why them being in theatre for a long time can affect that risk, and you don't have that understanding of the score, it's going to affect what score you give them. So ultimately, you can sit there and you can do a waterlow, you can do a Braden, but unless you actually look at your patient and assess them and do that skin assessment, you can get a lot more from your patient by talking to them, knowing their history and knowing if they're at risk, than, for example, something like a waterlow. And that's where you then need to go on to doing your pressure injury prevention planning. So that's where it's really good to have these plans into place and not think, okay, I've got a waterlow that's 25, but then not doing anything with it. What we want is to actually go, okay, their Waterloo's 25, that's really bad, or their Braden's 2, that's bad. What are we going to do with this information? We're going to turn them more often. We're going to put in those preventative strategies. And also what you want to do then is, if you know your patient is at high risk, you want to do this comprehensive skin assessment. And I do think up until recently, it's been a lot more focused on visual, but I think due to the emerging evidence that, there's a lot of these things like the SEM scanner that can help us, we need to do more of a comprehensive skin assessment. We need to get in there and touch them and feel those initial changes. And I think once you start doing them more and more, you'll actually get confident, and you can do them with colleagues as well. And then once you're feeling the normal tissue compared to that bony prominence, and you'll start getting an idea of what it normally feels like. And that's when you'll notice. I mean, trust me, if you feel a boggy patch, you'll know it's boggy.
Very good. I'll take this one as a comment, but I'll let you in on this one in any case, Andrew. It says, no need to answer for your hair, it's gorgeous. So there you go.
Thank you.
So there's one. But from the same questioner, they ask, once past the epidermis, are the vital signs in darker skin people similar to lighter skin, i.e. dermis and deep tissue? How common is use of SEM and skin assessment? Are both included on the monitor? I can answer the second part of that if you want to go to the first part there, Andrea.
So in terms of the colour, again, like I said, it's going to be very difficult to see those subtle colour changes. So when it's deeper, it is going to be how the temperature is, and as I said, it might be cooler in the centre, and it's going to be more about how that tissue feels. And I think that's where the issue lies in terms of assessing darker pigmented skin. And again, like I mentioned, it's not always going to be a purple or maroon. You might get slight differences in terms of a slight blue colour or maybe a bit black or grey. So it's just seeing those subtle changes. Does that answer that part, Phil?
I think so. Very good. There's a number of questions that have come in on the SEM scanner. Just to sort of outline the SEM scanner for you. The SEM scanner technology is a device that Arjo is providing to the market. The SEM scanner monitors subepidermal moisture. It is able to assess across a plane a moisture level and provide a delta that's indicative of moisture in the tissue that Andrea spoke about, that is a precursor to a pressure injury occurring. But what I will say about the SEM scanner, it unto itself drives practice. Then what Andrea is talking about, increasing mobilization, increasing turning, using alternating pressure mattresses as an example, then need to follow from the SEM scanner. So it becomes part of that total solution set. If people want more information on the SEM scanner, there is some information that we've put on the download, but just simply use Google. So if you put into Google SEM scanner or the word Provisio scanner, you will see that online. Hopefully that answers a number of questions that are coming through.
And I think just to follow on from that, Phil, we know that the more preventative strategies we put into place, the lower the risk. So if their risk is up here and you start turning them, you bring it down. You add dressings, you bring it down. You put in the SEM scanner, you're bringing down that risk. So every preventative strategy is helping to reduce that risk.
No, I couldn't agree with that more. This one's an interesting question. What is something we can say to patients to encourage them to prevent pressure injuries? Self-management.
Yeah, that is an excellent question. And I often, when I'm going around doing education within the district, obviously I'm English, if you haven't guessed by my accent, and in the UK we're often very time poor. So I would often get patients, relatives, carers involved in their care. And it's absolutely amazing and astounding what you can actually get relatives to do for you or patients to do for you if you explain. So, for example, the CEC has some excellent resources, and it goes through information for the patient, information for the family and carers, and that's in multiple languages. Just print it off, give it to them. But rather than just giving them this piece of paper and going, okay, there you go, do that kind of teach back, going back to them and say, okay, what do you understand by this? And I think once we then get them to understand a bit more the risks, and using terminology such as bed sores that they're going to understand. So starting to focus on what they can do. And I think if they have a bit more of an understanding of what it is and the little things that they can do themselves, you know, we can say, look, I understand that maybe this alternating air mattress feels a bit unusual to you, but we can start it off on an easier setting and then build it up. And things like that, as long as they're aware, these are all helping to reduce your risk. Even showing them pictures, you know, a lot of people don't like these gross pictures, and you can see numerous pressure injuries on the internet, on Google. So just going on there, you're going to get pictures, and I think once they realise, I know my dad has a disability and I showed him pictures, so now he's up and moving and he does a lot more things for himself. So yeah, just explaining and being a bit more proactive with them and try and get them, all the carers, to do as much as possible. We've all got 1,000,001 things we need to do. And we can teach them how to do skin assessments as well, how to look. Obviously, their bottom might be a bit more difficult, but there's, you know, other areas that they can see. They can keep an eye on these areas as well.
I think we've got time for one more question that's come through, Andrea. You know, above and beyond the utilisation of alternating pressure mattresses, pressure injury dressings, do you feel that manual handling equipment is also important in maintaining patient mobilisation and reducing pressure injury risk to patients?
Yeah, definitely. As mentioned, we know these extrinsic factors can have a big impact. So if we think about that moisture, shear and friction, we need to have those breathable manual handling. So for example, the plastic sheet and the draw sheet under a patient and using that to move them up the bed, that's going to increase that shear and friction. It's also going to increase the moisture. So we know the more layers we've got underneath a patient, the more risk they are of getting a pressure injury. So it's about trying to source products that have got robust evidence or that we know are tested to be breathable. And a lot of these alternating air mattresses have a breathability. So if you think about the fact that alternating air mattress is controlling the microclimate, and then if you pop in a plastic and a draw sheet on top, that's actually reducing the function of what that mattress is doing. So looking at the manual handling, using your slide sheets to move them up, but as well taking them out afterwards, because obviously if you're leaving it in, one, you're increasing the amount of layers between them, which is reducing that breathability, but you are also having them just slide down. So as soon as you move them up, they just go straight back down the bed, and that's just annoying for everyone. So it's definitely an important consideration.
Andrea, we're trying to get through all of these questions. There's a few, if I haven't been able to answer yours, we will answer them separately. But as an ex-intensive care nurse, Andrea, I think this is really a good question to finish on. It says, first, I would really like to thank you, Andrea, for this valuable presentation. It comes at the right time. My question is about using risk assessment tools in critical care. You said risk assessment tools are subjective. We know that ICU patients must be provided with all pressure ulcer measures done due to immobility. Based on your experience, is it helpful to use risk assessment tools in ICU or patients, or should we receive prevention measures regardless of the risk assessment score in the intensive care unit?
So really, really good question. And I think what we see from evidence is without using a risk assessment tool in an intensive care, you know your patients are at risk. They're the sickest patients. They're on a lot of support. They've got vasopressors. Their oxygenation isn't as good. They've often got a number of comorbidities. We've got to think as well with the increase in environment of obesity. So there's a lot of patients that come in with that, and thinking about a lot of patients that come to ICU have been pretty sick before they get to us. And so you've also got that malnourishment aspect. And if someone's malnourished, their skin is going to break down a lot quicker. They're going to get that damage. So I think the best way with an intensive care is you automatically think they're all at risk. Even your HDU patients, they are at risk. They're not mobilising. They're reliant on us. They're often sedated. So unless we turn them, they're just going to be lying there for hours. We're sorting out their incontinence, making sure they're clean and dry. And as we know, incontinence makes you 37 times more likely to get a pressure injury. And every single patient that's sedated is going to be incontinent. You've not got that control. So I think it's really important to just think they are critically unwell, they're in ICU, let's assume they are at high risk, and let's do as much as possible as we can. We know ICUs have a very high amount of pressure injuries, but again, they are preventable.
Very good. Thank you, Andrea. I think we're coming right to the bottom of the hour now. We need to go through the resources. So if you want to just run through your references there, Andrea, just for the purposes of running a webinar.
Yes. So most of them have come from the 2019 guidelines that were brought out in December. So you'll be able to find most of this information in there.
So RJ would really like to thank everyone for joining this webinar. Certainly thank you to the collaboration we received from the Australian College of Nursing. The collaboration that RJ enjoys with the College of Nursing is always welcome. We will be running these annual Stop Pressure Injury Day webinars again next year and into the future, and look forward to welcoming you again next year. If you would like to review this presentation, we will have recordings of this webinar available for you. The ability to see those recordings will be available at the RJO resources, so inquiries at rjo.com for further information. Once again, thank you. Thank you, Andrea, and hopefully in the last hour you've all increased your learning and your knowledge. Thank you once again.